I'm Dr. Andy Goodman. I'm a pediatrician and clinical professor at the NYU College of Global Public Health. And today I'm going to talk about value-based payment and population health. As you all know, DSRIP and the ongoing shift to value-based payment have increased interest in population health and prevention. Today I'm going to cover three areas related to this topic. First, I'm going to spend a few minutes on the goals of value-based payment and how they relate to population health. Second, I will be talking briefly about the factors that contribute to health outcomes, as I believe it is important that we consider these factors as we devise and implement strategies to improve the health of populations. And finally, I'm going to discuss strategies to address childhood asthma to illustrate how we can use a population health approach to improve health outcomes, and hopefully you'll be able to see how the asthma examples could be adapted to other health issues. Here we see the goal of value-based payment includes improving population as well as individual health outcomes. And it aims to do that through care coordination and excellent care. And as we will discuss later, there may be additional strategies that would be helpful as well. Here I have taken a few of the many guiding principles of value-based payment to highlight those that focus on population health and root causes or social factors that influence it. I think these principles indicate the growing recognition that it's important to address root causes that influence population health and that new strategies will be needed to address them. So, what is population health? Although the definition might seem obvious, it turns out that the answer to this question often depends on the perspective of the person providing the answer. In the early 2000s, David Kindig and others proposed a definition based on their review of the literature and talking to many people about it. His definition is based on the concept of a healthy population, and their simple definition here is the health outcomes of a group of individuals, including the distribution of such outcomes within the group. And while this seems pretty straightforward, it doesn't really provide much guidance about what to do to improve population health. More recently, the term population health has become very common among health care providers. And from that perspective, it typically refers to managing the health of a group of covered patients or a group of patients in a practice. And often it's a group with a particular diagnosis, such as hypertension, or patients that may share a risk factor, such as smoking. And it refers to how we're going to manage those individuals with those conditions. And it's usually through the provision of enhanced services, such as care coordination. However, if you're a public health practitioner, you're likely to think about population health, not as population health management, but an approach to improving the health of the entire population or groups of individuals with shared risks. The hallmarks of a population health approach from the public health perspective is, as I mentioned, it focuses on the entire population, and it also includes a focus on prevention, policy and system change, root causes or social determinants of health, and often cross-sectoral partnerships that are needed to address social factors such as housing or education. Now, before developing strategies to improve population health, it's important to have some sense of what the causes of poor health are. On this slide, I've listed the leading causes of death. And traditionally, when we ask about the cause of death, we have focused on the diagnosis or the underlying cause of death. Now, when we use data like this to drive our interventions, we tend to focus on healthcare solutions to improve health. So, for example, if heart disease is the leading cause of death that we want to address, it's not uncommon to think about what we really need then is more heart doctors to take care of that condition. Here, I've added a graph on what's called the actual causes of death that many of you might be familiar with. And as you may know then, over 20 years, some researchers did analyses that shed new light on the causes of death, what they call the actual causes. And here they used studies to estimate the number of deaths due to a particular medical condition that was attributable to risk factors such as tobacco use and poor diet. With this framing of the causes of death, we turned our attention to tobacco as a major problem, as well as diet and physical activity. And so this reframing of the causes of death prompted us to reframe our interventions approaches. And in fact, it did lead to the development of robust tobacco control campaigns, including taxes, counter-advertising, indoor air quality standards that have had a tremendous impact on smoking rates. Finally, here we will note that in the figure showing the determinants of health, you can see the importance of socioeconomic factors, commonly called the social determinants of health. This framework shows the need to go beyond healthcare services and interventions addressing risk factors for unhealthy behaviors such as tobacco to include socioeconomic or social determinants. Factors need to be addressed both for individuals, such as providing housing services for individuals, and for populations, such as new policies to increase the number of affordable housing units that are available. What I'd like to do now is just shift gears a bit and discuss a framework that we could use to design interventions to improve population health. This framework was developed at the Centers for Disease Control to improve population health outcomes. And I think it's helpful because it aims to bridge clinical and community services for patients, as well as aligning services for individuals with community-wide policies that affect the whole population. In bucket one, we focus on traditional care and really providing excellent care according to available guidelines. In bucket two, it's really referring to some of the services for patients outside the clinical setting, such as housing or food support, or preventive services such as the diabetes prevention program. And in bucket three, we see community-wide interventions, which are essentially policies or programs that influence the entire populations. And again, the tobacco example could be regulations on where you can smoke, or it could be soda taxes, or safe parks and streets to support walking and physical activity. So what I thought I'd do now is show you how the three buckets of prevention framework could be applied to the problem of childhood asthma. And again, hopefully this will illustrate how this approach could be used for this particular problem, but also could be applied to many others. Before describing the asthma interventions, I thought I'd take a minute to briefly describe a typical scenario that healthcare and other providers might face in taking care of a child with asthma. In this instance, this is a 6-year-old with poorly controlled asthma. As a result of that, he's unable to play sports, participate in gym and recess, because he's fearful of a triggering an exacerbation. He wakes up many nights coughing, and he's becoming overweight due to limited physical activity and lack of sleep. And in the past year, he's had 2 ED visits and 1 hospitalization. And although JD does have health insurance, he has other factors that are really making it difficult to manage his asthma. Poor housing conditions with mold and cockroaches. He has a neighbor next door who's smoking like a chimney, and the secondhand smoke is drifting into his apartment. His parents have his medications, but really not sure why they have 2 canisters and what each are for. And because they work long hours, it's often difficult for them to get to the primary care clinic when it's open, so they use the ED for primary care. So our approach using the three-bucket approach looks something like this. As I mentioned, bucket one is around evidence-based services and quality of care. And so in this instance, we want to be sure that healthcare providers adhere to the National Heart, Lung, and Blood Institute asthma guidelines that are in the expert panel report of the National Asthma Education Control Program. Some of the highlights of the guidelines are summarized here. And as you can see, they include getting a good medical history, asthma severity, asthma control, that they involve prescribing the right medications for the level of severity, and ensuring that there's sufficient education for parents about medications and addressing environmental hazards. In bucket two, we're looking at the second component of our intervention, which is how we complement what's going on in the clinical setting with community services. And for asthma, these services might include care coordination, home visiting, home interventions, and support from school health nurses. And as you can see, I also included some of the providers who are currently working on Staten Island to partner with clinicians to provide these services. In bucket three, we're thinking about the community policies that are going to affect the entire population, regardless of the severity of their asthma at any given time. And then this bucket might include things like policies to improve housing conditions, smoking policies in multiple dwellings, such as the ones that are currently going into effect in public housing. And it also could be organizational policies, such as school protocols, to better monitor the health of children with asthma. And finally, we shouldn't underestimate the role of healthcare providers and others in supporting these community-wide policies. And providers can play an important role, serving as experts to inform and guide policymakers about needed improvements, as well as advocates for healthy public health policies. And last, I'd like to emphasize that interventions with multiple components like this one for asthma generally require coalitions or partnerships with a designated convener to serve as a glue to keep all the pieces working well together. So in summary, I'd like to conclude with a few thoughts that I hope you'll keep in mind as you continue to work on improving the health of your patients. First, the goal of value-based payment is to improve both individual and population health outcomes. Second, to achieve this goal, we need to keep in mind that there are multiple factors that influence population health. Excellent clinical care, connecting individual patients to social and other services, and implementing policies to impact community-wide factors that influence health status. And then finally, the success of these approaches really requires the active and intensive coordination among all the partners working together to serve the community. Thank you.